I just did my medical school in Kingston. Kingston's a very friendly place, very focused on education, and I ended up deciding to stay here for my internal medicine and cardiology training. Even having our hospitals close together is, if you compare it to like Toronto or Vancouver or other cities, it's very convenient here. It's literally a 1-minute commute time to walk down the street. Conversations between learners and attendings to attendings and other like education collaborators just happens so much more easily because you run into someone and say, hey, do you have 5 minutes? Can we chat? The current fee-for-service model for physicians does not really reward people for spending time talking to patients and dealing with communication and family support. So I find that with the SEAMO model, when you need to take that time, you can take the time without sort of fear of losing out. Being part of an AFP allows me to every year negotiate with my division chair and department head what my role description is, what are my leadership commitments, my education commitments. And I've held several different leadership roles and been able to change over time. I think SEAMO gives me the flexibility to pursue those opportunities. It's a relatively small space, but the center of the Echo Lab, sometimes I call it the center of the universe because the reading room is a place where a lot of people come in to talk to us. They come to ask about echo results. They come to ask our opinion about how it might impact clinical care, what they should do. But interruptions is just part of being the person in the hot seat in the Echo Lab to be there to answer questions. So. I'm Métis. I'm originally sort of descended from the Riel line in the Red River, so I'm a citizen of the Manitoba Métis Federation. When I was a medical student, I was able to go up to Moose Factory for 5 weeks to do my family medicine rotation up there. I was seeing late stages of diseases that you just don't see down here because things weren't necessarily caught in time, and it sort of opened my eyes pretty early on to the disparities in healthcare, and that's sort of what drove some of my desire to try to change this over time. So one of my visions had been to try to see if we could embed an Indigenous lens through our curriculum and assessment processes. The first place I was able to do that was in the Masters of Health Professional Education program that was developed at Queen's. They have a course on Indigenous health education. We used a modified medicine wheel approach to grading. We then did not provide any specific grade to our students, but rather asked them to grade themselves on how they've grown and developed and met the objectives of the course. And one of the things we did with our assignments is we basically said, here's the topic, give us your assignment in whatever medium works for you. If you're a verbal person, do a podcast. If you're an artist, you can do a painting or do a drawing and just explain what it means. I would say we have almost never had to change a student's self-grade, and if we did, we often upped it because they were usually harder on themselves than we would have been, to be honest. We should be teaching too how do you best take care of the patients? How are you going to best serve the population that you're planning to serve, as opposed to how are you going to pass that obscure biochemical question that's going to show up on the exam. I actually do think that the ability to be on an AFP, the alternate funding plan through SEAMO, was actually a huge part of me coming here. That was huge. I don't know if I would have been as successful at implementing some of these education changes in a place that didn't have an AFP.